Hello everyone, and welcome to today's webinar. My name is Sherlyn Chen from Boehringer Ingelheim, and I will be your moderator for today's webinar that is organized by the GastroPlus User Group. Today's presentation is titled Applications and Considerations of Drug Exposure Predictions in Pediatric Populations using GastroPlus. This presentation will be given by Dr. Viera Lukacova from Simulations Plus. Viera is a team leader at Simulations Plus, where she contributes to research and development and oversees a team of scientists, programmers at Simulations Plus in developing software programs such as GastroPlus, DDD Plus, and Membrane Plus for simulations of absorption and bioavailability, in vitro dissolution, and cell culture permeability simulation. In the recent years, her main research focus was in the area of PBPK modeling and drug-drug interactions. Following the presentation, there will be an opportunity to ask questions. This webinar will be recorded and will be available to the user group members in the future. So without further ado, we now begin the webinar presentation. Viera.
Thank you, Sherlyn, for your kind introduction, and thank you everyone for taking the time of your busy schedules to listen to this presentation, basically summarizing the possibilities of simulations of pediatric prediction and focus mainly on GastroPlus, of course. I will be going a little bit in the reverse order compared to what the title says. We'll start with the considerations describing the physiologies first, and then in the second half of the talk, we'll be also looking at some examples and applications. So this is just the outline of the talk. As I mentioned, we'll start with descriptions of pediatric physiology, what is known, what assumptions we were making, and so on. Then going more into so the first part will be more focused on the growth and development, and the second part more on the functional development. So looking at the mechanisms of clearance, disposition, and these will be also supported by some of the examples for pediatric predictions or the scaling in GastroPlus. So starting with the physiology, and I'm sure you are all well aware of these aspects, but just as a reminder of what are the conditions or what are the aspects of physiology that we need to worry about when we are trying to go into the pediatric predictions. So we are looking, of course, at the scaling of the entire physiology in terms of individual tissue sizes, blood flows, and so on. But in addition to that, we also need to worry about scaling of the intestinal physiology. Especially for the oral dosage forms, we need to account for the drug movement through the intestinal tract. What are the differences in the dissolution, transit times, in the absorption rates, and so on. So we do try to scale the intestinal physiology as well as the full PBPK physiology. And when we talk about PBPK, we mainly mean the individual tissue sizes other than the intestine, blood flows, compositions, and so on. Within GastroPlus, for those of you who've looked at any PBPK type modeling in GastroPlus, you know that the program does include two physiologies or two populations for human, American, and Japanese. And that for the human physiologies, you do have automated way of creating physiologies for age, specific for age and for gender. So just a brief overview of what went into creating these algorithms, or what kind of scaling you actually see when you rely on this automated generation of the physiologies, to give you a better understanding of what assumptions were there and what limitations these may have. The first and basic scaling or basic assumption is for the total body size, and for this, for the American population, we are using the data collected by the enhanced survey, looking at the body sizes from the children up to the adults, and similar plot we have for body heights from this survey. For Japanese physiologies, again, we had a publication based on the Japanese, similar publication based on the Japanese population. Of course, it's not all about the total body weight and height, but it's more about the development of individual tissues. And I'm not going to go through every single tissue and showing you the plots or equations for every single tissue, but just to highlight a couple of those. For some tissues, we are dealing more with the monotonic increase. It may not be necessarily a linear increase. There are non-linearities with different ages or different development stages, but it's more of a monotonic increase with the age. But there are also tissues, and adipose being one of those, where it's not just a monotonic increase, where especially in the first year we are going through sort of a increase and then dropping down as the baby start walking, lose that baby fat, and the percent of body fat actually drops at a certain age. The other aspects that we need to scale are also the organ blood flows. So it's not just the tissue size, but also the rate at which the blood is able to bring the drug into the tissue. And again, based on the publications, we were able to find information that allows us to scale or to relate the tissue blood flow to the tissue size. It becomes a little bit more tricky when going down to the infants, especially infants below 1 year old, so newborns, neonates, and infants. And for those of you who've been using GastroPlus for a longer time, you might know already that it took us a little while longer to actually add these physiologies for less than 1 year old, just because of the additional complications and rapid changes in the physiologies within the first year. And what we were looking at here was the effect of not only the age, but also gestational age. So this is where we had to look at not only the age of the child after the birth, but also how the gestational age or possible premature birth would be affecting the sizes and the physiology in general. And for most of the tissues, we actually have a pretty smooth function going from the conception all the way up to 1 year old. So the birth, at least based on the information that we were able to find, did not cause significant change in the rate of the development. We had smooth function. You should probably describe on most of these plots showing, especially for the infants, the x-axis is shown as postmenstrual age, meaning gestational plus postnatal age. The yellow line is showing 40 weeks, so that would be a full-term birth, and it ends at 1 year old, so that would be at full-term 1 year old, so about 92 weeks of postmenstrual age. And for two examples, kidney, liver, you can see very smooth transition through the birth. It did not introduce any significant non-linearity. And this was the case for most of the tissue sizes. When it comes to tissue sizes, the exception really was the adipose tissue, where based on the information we were able to collect in literature, the prematurely born babies actually go through something called catch-up period, where they actually accumulate fat a bit faster than their full-term born controls, and they will equalize at around three months of age with the full-term born babies. So on the left, you are seeing a plot based on the showing percent fat mass for full-term born babies, the blue line for boys, the red line for girls. The yellow were showing where from the studies where the gender was not specified and which only had a general percent fat mass. And those curves, the blue and red, are shown as the black curves here on this plot, and you can see that the preterm babies born premature would have a bit higher percent body fat for the same postmenstrual age as their full-term born controls. So this is also accounted for in the algorithms when you are generating the physiologies in GastroPlus. For the general tissue composition, as you know, one of the basic algorithms or assumptions for the distribution are the tissue plasma partition coefficients, which we are using to account for the distribution into the tissues. If there is no significant permeability limitation, if we assume that the blood flow is the only limitation to the drug distribution, the tissue composition is a significant aspect in calculating tissue plasma partition coefficients, or how much the drug will be distributing in the individual tissues. So again, accounting for the changes in the tissue compositions throughout the growth and development of a child becomes a significant aspect in predicting these tissue plasma partition coefficients. And it again becomes more significant in the first year of age. As you can see, again, I've shown only a couple of examples here. Adipose, which is showing more dramatic changes, especially in the first year. But also after that, the first year would end about here, and we are going here up to adulthood. So we are still seeing quite significant changes in the adipose tissue composition between one year and the adults. It's not as dramatic for what we call normal tissues or non-fatty tissues. A brain is shown as an example. Again, going from 1 year old all the way to adulthood, we would see changes in few percent in the lipid and in water content. But so it does become more important, especially for the infants, but we are accounting for those changes throughout the entire continuum all the way up to adulthood. When it comes to the water in general, you can see there are, again, significant changes, especially in the first year of age, that would end about here at 92 weeks post-menstrual age. And again, especially the prematurely born babies are basically all water, and the water starts changing, evaporates. The composition of the body is changing very quickly until it levels off at about 60% for total body water and about 23% for extracellular water, and stays up to adulthood. So again, most significant changes that we need to account for are especially for the neonates and infants. The other parameters that we of course need to account, especially for the aspect of distribution but also for clearance, are the plasma protein binding and binding to red blood cells. As you know, for a lot of drugs with a significant binding to plasma protein, clearance or distribution of the drug can be significantly affected in the children. And similar for the hematocrit. If the drug has significant binding to red blood cells, then the portion of the red blood cells in the blood will again affect the distribution of the compound. And here we had a little bit simpler situation for the plasma protein changes, and we are showing here plots for the two major drug binding proteins, alpha aminoglycoprotein and albumin, where we have more or less monotonic distribution or the ontogeny or development throughout the age, and we are ending with 1 year old here. It's a little bit more complicated with hematocrit, where you would see significant changes in hematocrit within the first few weeks after birth, and these are also dependent. So the rate of decrease in hematocrit is about the same regardless of whether the baby was born premature or at full term, but the starting point on the decrease will be dependent on the age of birth or on the gestational age. Just to give you a little bit better overview, what you are seeing here, the red points are showing the changes in hematocrit in fetus. So as the baby is developing in uterus, how the hematocrit is increasing. And at birth, within the first 3 or 4 weeks after birth, the hematocrit drops significantly. So, and the rates are about the same, shown here for babies born at 29 weeks. This one was 33 or 34 weeks, and this was a full-term born babies. Again, the hematocrit was dropping significantly until it reaches minimum about 3 or 4 weeks after birth, and then starts steadily increasing until it reaches the adult values. So again, this is something that we needed to account for to have especially accurate or more accurate description of the binding to red blood cells within the first month after birth. And we did incorporate that as an automated scaling within GastroPlus under assumption that the parameters that you are entering, the blood to plasma concentration ratio and the fraction unbound in plasma, are representative of the adult blood. You do have option, or you can turn this option off in cases that you actually measured these parameters in the blood corresponding to the age that you are trying to measure, that you are trying to simulate. So if you are entering the blood to plasma ratio and FUP corresponding to the age of the child that you are trying to simulate, you would turn off these options so there is no additional scaling. But if you have the typical scenario where these parameters are representative of adult blood, the program will automatically scale it to the age that you are trying to simulate. And it's not done all just in the background. You have an option to view it. We sort of ran out of real estate, but we did give you an option to pop up a description and look at the scaling where we are showing you the adult values, how the physiology for the current child or for the current physiology is different from the typical adult, and what changes in the blood-to-plasma ratio and fraction unbound in plasma or the plasma protein binding it would actually cause. Couple more words about the plasma protein binding scaling. And the equation that we are using was published back in 2002 by McNamara by looking at the scaling based on the protein in the pediatric or at given age and in the adult protein levels in given age and in adult. But the algorithm that they suggested was looking separately at the albumin and at alpha acid glycoprotein. So distinguishing what is the major drug binding protein for every compound, and then applying the ontogeny of that specific protein to scale the FUP. We tried to simplify this approach a little bit, and instead of looking at each of these proteins separately, we are looking at total plasma binding, total plasma protein levels. So considering both albumin and alpha acid glycoprotein in single protein fraction. And this is showing a comparison. On the left, you see the data from McNamara's publication scaling or predicting FU in children based on and comparing it to the observed FU. And these represented values for ages 1 day through 4 months old. So really young neonates and infants. And this is the performance of the scaling based on the major binding protein. So for each compound, distinguishing whether it's binding to albumin or AAG, and scaling using ontogeny of that protein. On the right, you see the scaling based on the implementation in GastroPlus, where we are looking at the total plasma protein. And you can see that there isn't much of a difference in the performance. Maybe this one outlier is a little bit bigger outlier in the total binding protein than it was using the major binding protein. But other than that, there really was no difference in the performance of the models. So we stuck with the simpler strategy of using the total plasma protein rather than having to distinguish those two proteins. So how do you actually create these physiologies? How do you account for all of these processes? It's very simple within GastroPlus, where you simply define whether you want to create a physiology for male or female and define an age. And in the cases where you are trying to model less than 1 year old child, you would be also defining whether this child was born at term or whether it was premature, because some of the physiological parameters we had an information that the gestational age is affecting the ontogeny of that process separately from the postnatal age, so we need to account for both. So that was all looking more at the PBPK physiology. So tissue sizes, blood flows, tissue compositions will go in the next, in the second part of the talk. We'll be talking more about the enzymes and transporters, but this was more about the overall tissue ontogeny. So the other aspect is looking at the intestinal physiology and the growth. Far less information is available, less details is available for the intestinal physiology than for all the other tissues. For some parameters, there is very limited information available, things like gastric emptying or transit time, where we were seeing quite conflicting reports, and a lot of this was dependent on the measurement method. Which methodology was used to measure the transit time, we would see the differences in the transit times between older and younger children, or would not see the differences. So that makes the interpretation a little bit more complex. For other parameters, we had more qualitative information rather than actual quantitative information that we would be able to incorporate in the model. Things like the villi structure is not well developed in infants less than 3 years old. So this would be affecting your absorptive surface area. We know that it may be lower in these very young infants, but by how much, we really don't know. We don't have that kind of information. So for now, we had to keep it at the adult level. But in terms of building the model, this is something that you should be keeping in mind when doing the predictions for these very young children for the oral dosage forms. And keep in mind larger uncertainty in the absorptive surface area that would be affecting the rate of passive absorption. The other parameter are the bile salts. Again, we've had qualitative information that the bile salt composition may be different in very young children, that the site of reabsorption may be different in the very young children. Again, something that we know it may be different than in adults, but by how much and where exactly is it changing, we were not able to put it yet into any quantitative information or into any quantitative measures. So for now, the bile salt concentrations in the intestine remains the same for children as for the adults until we are able to get more of the quantitative information. But again, something to keep in mind, and realize that you may have large uncertainty when predicting the absorption or dissolution and absorption in the very young children, especially for the compounds that are showing very high effect of the bile salts. Of course, if you are dealing with a compound which is not showing much effect of bile salts on the dissolution rate, you don't have to worry about if you are dealing with more lipophilic compounds. Again, something to keep in mind that there may be a bigger uncertainty. For some parameters, we did have quite a bit more quantitative information, things like stomach pH, where, again, it's probably more well-known fact that the stomach pH in newborns and neonates is higher, but again, very quickly, within a few weeks, it drops down to the very acidic condition, and basically it drops down to adult levels. Stomach volume, even though for this one, we just recently became aware of additional publications that are showing slightly different or quite a bit higher stomach volume than what we had from the original publications, so we might be revising that in upcoming versions. Intestinal length and radius, this is something that we developed or back calculated based on changes in the entire intestine growth. Again, we assume that it's growing proportionally, so we were able to scale the adult lengths and radii down to pediatric. Transit times, again, we did have quantitative information, but keeping in mind comment that I made earlier, these may be very dependent on the measurement method, so a little bit more uncertainty there. And when it comes to enzyme and transporter expression levels, we did have a good information for 3A4, not much for other enzymes or other transporter expression levels changing in the intestine. But for now, we at least can change or modify the expression levels per intestinal compartment simply by the surface area, assuming that the density per centimeter squared is the same as in adults. We can at least scale it by the tissue size, even though very likely, at least especially in the very young neonates and infants, the functional ontogeny is going to be different, and even the expression or the density of the expression is not going to be the same as in adults, but that's the information we have for now. The other aspect that you may want to consider or you may want to account for, especially in the very young children or again in the neonates and infants, is the growth of the child. If you are working on the studies or trying to work on the populations of older children or adolescents, 4 or 5 years old or older, you don't really worry about the growth of the child within your week-long study. The 1 week or even 1 month is not going to create that significant difference in the physiology. But if you are dealing with neonates and infants and you are looking at the study at the longer term, maybe 5-10 day study, it does make a difference. The 10 days old baby will be very different from your 15 days old baby. So this is something that you may need to account for in your study design. And it's something that you can do through our mixed multiple doses functionality, where you can define the exact growth of the child through this file. Implementation through this mixed multiple dose file is sort of a blessing and a curse at the same time. The curse is in the fact that you have to create this mixed multiple dose file and you have to assign the physiology to each day of dosing and gradually growing that child. So you need to pre-create those files for each age as the child is going through the study. The blessing is in the fact that you have a complete control over how that child would be growing. So you don't have to worry about is it going to be a typical growth curve or not. You can account for any types of changes in the physiology that you would expect in the child throughout your study, and through that accounting for the condition, how the condition that you are trying to treat might be affecting the typical physiologies, maybe even account for a baby possibly losing weight throughout the course of the treatment and so on. So in that case, it really does give you a complete control over modeling the scenarios that you that is really relevant for your compound. So that was more description or brief overview of some of the assumptions that went into generating the physiology in terms of the overall growth of the child, growing the tissue sizes, growing the whole body, changing the compositions of the tissues and so on. Now the second part of the talk will be focused more on the functional development, or how the processes of the clearance or transport mediated disposition are changing with the age, at least the information that we were able to find. And starting with the what seems to be the best characterized process so far is the metabolic clearance. And if we are starting with the best characterized processes, then of course we'll start with the CYP enzymes, where back in 2006, the publication by Trevor Johnson nicely summarized the ontogenies for the major CYP enzymes in liver and for CYP3A4 also in the gut. So from their publication, we have the complete equations that were implemented in GastroPlus, and here are the plots showing the development of individual CYP enzymes in the liver. And as you can see, for some enzymes, the complete curve is well characterized. So we were able to see exactly where it reached the adult levels. For some enzymes, we have some gaps in the data. So things like 1A2, where we have the last measured point at, I think it's about 1 year old, where the expression level reached only about 50% of the adult. And then we have a 10 years old where it reached the adult levels. So not really knowing what's happening in between here. But for most of the enzymes that we don't have that kind of gap. The additional information for, especially for 3A family is, as you know, that switch going from 3A7, which is prevalent in the newborns, and as it's slowly transitioning into the 3A4, which is present in adults. And this was developed, or the expression levels were characterized based on the functional characterization or the activities of the enzymes that we again got from the publication. So within GastroPlus, you now see the expression levels changing. If you start with your newborn 2 days old, it's all 3A7. As you are looking at the changes as for the 6 months old, 3A4, 3A7 are nearly the same. By 1 year, it's really the 3A4 that dominates. And by 5 years old, very little 3A7 would not have an effect, and we don't even have it for the adults. So these are accounted for within your physiologies. And similar plots we have for the intestinal 3A4, as I already mentioned from the publication by Trevor Johnson. Changes in the 3A4. Intestinal 3A4 actually lags a little bit behind the adult, where the 3A4 is close to adult levels within about 2 years. By 5 years, it is at the adult levels. But the intestinal one takes quite a bit longer before it reaches adult level. And our favorite compound, midazolam, the poster child for the 3A4 ontogeny, this is an example that you've probably seen multiple times, showing the prediction of pediatric disposition of midazolam, accounting for the physiology changes as well as the 3A4 ontogeny. Recently, we've had a collaboration with a group at University of Florida, Stefan Schmidt's group, and Tanay Samant is a postdoc who did all the work there, where they were looking at additional enzymes, additional compounds metabolized by CYP enzymes. And the overall goal was actually looking at the strategy of characterizing or using the specific substrates of the enzymes to characterize or to validate the ontogeny of the enzyme, and then once it's validated, using it to predict the PK of a compound which might be affected by more than one of these enzymes. So they've selected number of specific CYP substrates for different CYPs that actually play a role also in acetaminophen. And this was their final test compound, which is metabolized by a variety of enzymes, contributing several CYP enzymes, as well as UGTs and sulfotransferases. And the model development was your typical model development, as what you would do, starting with the adults, taking some published studies to develop or to calibrate the model in adults against IV and oral data were available. Then taking different studies in adults to qualify the model or to use the model previously developed using one set of studies to just do a predictions for different set of studies, maybe different dose, different subjects, just to see how robust the model is and how well it's predicting in adults, and then going into using that model to predict the pediatric for each of the enzymes. And here are the summary of the results. And again, this was published or presented in a poster a few months ago at the ASCPT meeting. And these are the summaries for the specific substrates for the 5 different CYP enzymes. And you can see the performance was overall pretty reasonable. There are some enzymes where the clearance was underpredicted. Let me back up here a little bit. It's a little bit more difficult to find the full CP time profiles in the literature, especially for all the pediatric groups, but it's easier to find the reported clearances. So the comparison is based on the clearances where Tanay would do the simulations or predictions of CP time profile for different ages, then use non-compartmental analysis of the simulated profile to get the simulated clearance and compare that with the observed data. So the lines are showing changes in the simulated clearance with the physiologists from GastroPlus. The points are showing the observed clearances from different publications. And for some of these, we do have a bit of underprediction. For others, we have a very nice match. Again, midazolam, something that we would expect. But we also got a nice match for omeprazole across all the ages, accounting for high polymorphism of that enzyme. For 2D6, we did not have well characterized the very young, but the lowest age, 8 years old, was predicted very nicely. We did have some mispredictions for 1A2, even though for caffeine, it's again a little difficult to figure out whether this is because of the enzyme ontogeny or just the variability in the populations, because we are nicely matching here. We have some of predictions or under predictions of clearance here. For theophylline, again, we are very nicely predicting the clearance in the very early young neonates. We seem to have a bit of under prediction in this range between maybe 2 and 10 years old. So looking back at the ontogenies, this may be simply because of the function where there was interpolation between those 1 and 10 years old. Maybe the functional form is slightly different at this age, and that might help us to get better prediction on the clearances here. While compared with the 3A4 and 2C19, these are those enzymes which were very nicely characterized throughout the entire age continuum, so we don't have that kind of gap in the enzyme ontogeny, and ended up with better predictions of the clearances across the entire age. So the final stage in this project was once we were okay with predicted with how the ontogenies are looking at are able to predict the specific substrates. They were used to predict the acetaminophen, and again going from adults and scaling down to adolescents, infants, as well as neonates, you can see all of them gave very nice predictions for this final compound. So the strategy worked very nicely using the calibrated or the validated ontogenies to predict the compound, which may have contributions from multiple different enzymes. Of course, the simulations are not limited only to CYP enzymes, even though we don't have built-in ontogenies for any other enzymes right now. It is possible to do this. It would require a bit more work from you as a user to estimate how these enzyme expression levels might be changing. If you do see any publications showing ontogenies for other enzymes, if you point us to those, we'll of course add them to the program, make this process easier for you. But as this publication by Roche in 2011 demonstrates, it can be done even without the built-in expression levels, where they were looking at the oseltamivir or the Tamiflu simulations metabolized by carboxylesterase into the oseltamivir carboxylase. So again, by going with the standard strategy of developing and calibrating model in adults first and then predicting the pediatrics, they were able to get a very nice predictions for the 5-year-old children shown in here on this plot. The next major clearance pathway, renal secretion, and I will have a couple of more examples for the renal secretion, but within this section, more focus on the glomerular filtration. And again, there was information about how the GFR is changing, and more standard example again for us, the gabapentin, showing how the program developed and again validated against adults was then able to predict the gabapentin exposure in children, and these were about 7-year-old children for gabapentin. So showing the effects of the glomerular filtration changes. It does become a bit more complex again once we go into the neonates, where this is one of the parameters where again both the gestational age as well as postnatal age have their own separate effects. The glomerular filtration starts increasing or rapidly changes few days within the first few weeks after birth. So it starts increasing rapidly right after birth, and so this start would be dependent on when the baby was born, but again, this would be dependent only on birth after about 33 weeks. If the baby is more premature and was born before about 33 weeks, before the nephrogenesis was completed, you won't see that immediate rise in the GFR until the nephrogenesis completes around 33 weeks, and then it would start increasing. So again, a little bit more complex treatment that we had to include, but all of these processes are again included in the physiologies to account for more rapid changes in the GFR in the very young neonates and infants. And going into the probably the least well characterized processes, and these are processes related to the transporters. What we need to deal with when it comes to the transporters, these are affecting the distribution into the tissues as well as clearance. And what we need to account for is, of course, the effects of the transporters, influx or efflux transporters. But along with that, of course, we are dealing with the permeability limited tissues. So these the transporters are important in the aspect, especially in the aspects of the low permeability compound. So we have actually two processes to scale. One is that low passive diffusion through the cell membranes, and the other is the effect of the transporter. When it comes to transporter ontogeny, there is very little information available in the literature on the ontogeny of individual transporters. Here is just an example or a snapshot of from one publication showing some information, more qualitative information about the changes in PGP. There actually is a publication coming out in CPT, a nice summary put together by Kim Brower, doing a overall, or organized by Kim Brower, put together by Pediatric Working Group, where they summarized information, all the available information on ontogeny of transporters in liver, gut, and kidney, so something that you may want to look into. But overall, it's not as well characterized as the CYP enzymes would be. We do have some additional information for maybe other compounds, so the clearances of other compounds like para-aminohypurate, where we don't have the ontogeny of the renal transporters, but the clearances of para-aminohypurate, which is also excreted actively via transporters, are characterized at different ages, including the very young neonates and infants. So we were also exploring options of how to utilize this information and scaling that, translating it into more physiological information and using it to predict the clearance of other compounds. And I will show a couple of examples on that aspect. When it comes to that passive permeability, again, the main aspect here would be ability to scale this to smaller tissue sizes, right? The standard parameter that we use to account for the passive diffusion through the cell membranes is this permeability surface area product. So, and that becomes difficult to scale because we don't really know the surface areas of individual tissues, not even in adults, but not to mention at the pediatrics. But if we make some assumptions again, if we assume that average cell size is about the same across the tissues, then we should be able to scale this permeability surface area from one tissue to another, right? So, and again, we would be assuming when going to pediatrics, we would be assuming that as the tissue grows, it's not that each cell grows as much as it's adding new cells to the tissue. That's how the tissue grows. It's increasing the number of cells rather than creating some giant cells. So now the key would be to figuring out one permeability surface area product for one of the tissues, and then through cell volumes of the tissues, we would be able to scale it to all the other tissues. And here is where the problem becomes a lot simpler. And to make it really more straightforward, we introduced new parameter called specific PSTC, or permeability surface area product per milliliter of cell volume. And this is an important aspect. It's not the total tissue volume, but it's a cell volume. This becomes important, especially again for the young neonates and infants, where the fraction of extracellular space and the cell volume is changing, but it's cell volume that accounts for the surface area. And we were able to take this process of scaling all the way from the in vitro data, where you could get the diffusional clearance from your in vitro experiments. We would scale that to in vivo liver permeability surface area product. And once we have it for one tissue, we could calculate this specific PSTC per cell volume. And then it would be easy scaling to go into all the other tissues. And again, once we have this specific PSTC, we could apply it to predict the PSTC values for adults as well as for pediatrics. And within the next few examples, that's exactly what was applied. First example is valsartan. This is compound which is cleared by biliary secretion, and it's a substrate for OATPs in the liver to uptake the drug into the liver, and then MRP to efflux the drug into the bile. And we had the data in vitro, again publication by Roche, in vitro data measured in rat and human hepatocytes, and in vivo data in rat and human, in adults, and then also use the data for pediatrics to validate the scaling down into the children. So the complete model did include the permeability limited tissues with the transporters in the specific tissues where they were relevant. And for MRP2, since it appears in several tissues, we also used a publication scaling the MRP expression levels through different tissues. And the whole process started going from in vitro to in vivo data. So as you would go with your process starting with the animals, if it works nicely, you go to the human. Again, prediction in human was reasonable as first in human prediction, but not something that we would want to use for pediatric prediction. So we took this adult model and recalibrated it against the in vivo data before, so refined it by refitted that passive diffusion and intestinal permeability. And once we had a model that was calibrated against adult data, we used this same model to predict the pediatric populations. So all the drug-dependent parameters would stay the same. We just changed the physiologies. And again, because we did not have information about the ontogeny of the transporter, we started with the assumption that the transporter density would be the same as in adults, meaning the expression per tissue size stays the same as in adults, and the total expression was just changed by tissue size itself. And we did the safer process, starting from the oldest children, assuming that here the expression would really be closest to the adults, and would be making adjustments if needed for the younger children. And studied from the adolescents. Very nice prediction, so no changes to the enzyme, to the transporter expression levels were needed. Even going to the younger children all the way to about 4 to 6 years old, predictions did not give us any indication that we would need to make any changes to the transporter levels. We started having some over predictions going to the very youngest group, about 1 to 4 years old. But here we also looked at whether this could be more due to absorption, because these were all PO doses. And you recall where I was pointing out some of the qualitative information on the intestinal ontogeny. One of the parameters was underdeveloped villi in children less than 3 years old. So we looked at whether that could be an aspect for this underprediction for these first 3 points here. And what we've done was decreasing absorptive surface area, and we got a good prediction. Again, something that we were not able to do a priori, because the information is only qualitative, so a priori we were not able to put a number onto it, but it did help us to explain the overprediction for these very young children. Another example where again transporters play a role is amoxicillin. This one is eliminated by renal secretion, and it's glomerular filtration and active secretion with the transporters. So we have several transporters playing a role, and we started process with developing the model, and I'll skip through the model structure again, putting in transporters where needed in the tissues. And we fitted the adult model against the adult data in IV doses as well as PO doses, and for some of these we also had the urinary secretion. So quite a rich data set, allowing us to really zoom into all the processes affecting the transporters on the absorption for the peptide-1 in the intestine, affecting the absorption of the amoxicillin, as well as the renal secretion and the transporter involvement for the renal secretion. Once the model was developed and fitted against the healthy subjects, it was validated by predicting the PK in subjects with renal impairment, with different degrees of renal impairment, and you can see that it nicely predicted all of the groups. So now we had more confidence going into pediatrics. And for this one, we were able to find the CP time profiles in infants, 10 months old through 3 years old. And if we assume the same transporter density as in adults, you see that we would end up with overprediction of the clearance. So the CP time profile slightly underpredicted. And it may not seem very significant on these plots, but you can see that they are all on the log scale. So the underpredictions actually were quite significant. So we looked at, is there something else that we can use to scale the transporter ontogeny, since we don't have the exact numbers for the transporters, but can we glean this physiological information from somewhere else? And for this, we looked at the compound which is secreted in urine by active secretion, the para-aminohippurate, and the clearances were reported for the wide range of ages, going from really newborns all the way up to adults. So we looked at these, and for the ages that we needed to model, we had about 50% and about 66% for the 3 years old. So by scaling the transporter expression levels in the kidney by these fractions, we would really get a nearly perfect predictions for all of these different ages. And taking this even further to really newborns, we had data for preterm newborns, 29 weeks of gestation, and we had data from 2 different publications for 3 days old and a combination of 1 through 3 days old. And again, if you look at the very low expression levels, we assumed it would be only about 2% of the adult values. Again, it gave us got us close to predicting the CP time profiles for these neonates. So again, showing that the strategy of using the clearances for the compound with a similar clearance pathway to glean the physiological information and use it to predict the PK for other compounds may be a valid approach. And the last example was acyclovir, which we just presented again a few months ago at the AAPS meeting. This compound has a combination of the clearances, so there is some metabolism, renal and biliary secretion. And again, the process was the same as with the previous compounds, using adult data to characterize the model, and again using adult data after IV and PO administration. We also had data for cumulative excretion in urine, which really helped us to figure out the proportion of liver versus kidney clearance. So first step was really get the adult model, and then using that model to predict the pediatrics. And what you see here is the predicted clearance in the red and predicted volume of distribution in blue. And you can see the volume of distribution was predicted very nicely with the specific PSTC value accounted for. The clearance, we are okay on going from about 1 year old up. The only one where we over-predicted clearance was the 1 to 3 months old. And again, applying the scaling of the transporters, just like we previously done for amoxicillin, using the scaling as for pack clearance, we got much closer to predicting the clearance even with the youngest age group. So these are some strategies and that we've used in the pediatric scaling in the past. So to sum this up, you do have good algorithms for creating physiologies from 16 weeks premature newborn. You can account for the growth of the child. Again, it does require more work with setting up the model, but on the hindsight, you do have that complete control over the growth of the child, so you can account for the condition of the child for the patient. Known differences between children and adults are incorporated as much as we could in the expression, in the tissue compositions, blood character, blood parameters, glomerular filtration rate, but there are still some gaps in knowledge. The most gaps are in the overall intestinal physiology, where a lot of information is more of qualitative nature rather than quantitative information. And of course, the ontogenies of enzymes and especially transporters. We have well-characterized CYP enzymes. There is some information available for UGTs, but for transporters, it's really becoming a more difficult aspect. But we have started exploring the processes of learning from compounds with similar pathways, and the aspects that we explored, or the compounds that we used so far, did work very nicely. Of course, we need to continue on this path of exploring this approach or validating this approach but so far it's showing a promising result. So this could be used as a substitute for the unknown ontogeny of the transporters. And to wrap up the talk, just the acknowledgement, again, this is work, everything that we've been presenting was done by GastroPlus, even though I did steal some of the examples, not just done in our group, but some examples from the publications. So I forgot to put here the acknowledgements to the groups from Roche, where I used their oseltamivir example, or the group at the University of Florida who did the CYP work. When it comes to the program development, we have the Simulation Technologies group, and of course all the other groups within Simulations Plus. So now that concludes the talk, and I think we still have some time to answer questions.
Thank you very much, Viera, for the great presentation. At this point, we will open up for questions. I saw there are written questions, as well as the some of the people from the audience raised their hands. So our first question is from Patrick. Is the scaling of blood plasma ratio using only hematocrit, or also considering plasma protein binding? considering the plasma water to red blood cell ratio?
So the red blood cell, the blood to plasma ratio is really mainly the hematocrit. So accounting how the proportion of the drug in the whole blood versus only in plasma would be affected by changes in the binding to red blood cells. For binding to the protein, we then have the fraction unbound in plasma. So blood to plasma ratio splits our drug into the drug bound to red blood cells, and that's affected by scaling of hematocrit, and the rest of the drug, which is in the plasma. And within the plasma, this would be the total drug, so bound, unbound, and that we then scale by the protein changes.
Thank you, Viera. I have Beverly Patterson. I have unmuted your line. You can go ahead, ask your question. Beverly? All right. To move on to the next one. Hello?
Beverly? You are unmuted. You raised the hand that you wanted to ask question. Okay. Then maybe we can go to the next one.
We can move on to the next one. The next is from Farrell. You're unmuted now. You can go ahead and ask a question. Hello?
Who was that?
Farrell. Yeah, I saw the little hand, but I saw quite a lot of written question came in. Maybe I'll just start reading from the list. For scaling pediatric plasma binding, it seems like 2 groups for correction instead of 1 correction.
I'm not sure exactly what you mean 2 groups for correction. We did look at the, and let me go back to that slide. We were trying to look at both major proteins, the albumin and alpha acid glycoprotein, but it seems like the ontogeny of the of those 2 proteins is the rate of ontogeny is fairly similar. So regardless of which would be the major binding protein or whether the drug is binding partially to each, by using just the total protein, accounting for ontogeny of both of these, seems to give us a reasonable scaling from adult down to pediatric. I'm not sure if I answered that question.
Okay, thank you. The next question is...
Actually, it seems like Hiro does have a follow-up, so...
Yeah, hello.
Yep.
Actually, that was my question. So, at this moment, you're showing that the slide here that so there's a nice correlation here, but also kind of lower parts, especially when you look at it, 0.2 and a 0.4, binding rate. So if you put the kind of straight line there, one of the 0.8 outliers actually not the outlier anymore, because another group of kind of protein binding groups there. So that's what I meant about kind of 2 groups actually.
So you meant if there was another correlation down here. Yeah, the problem is that we were not able to find any special characteristics of the compounds that would distinguish these. So it really was not, and even within this one where they were looking at major binding protein, I don't think that these were compounds that would be specific to only one of those proteins. So we were not able to find a special characteristic that it would be distinguishing these outliers that would allow us to do additional scaling.
Okay. Since I'm on the mic, and actually next questions, I kind of wrote it down there. So earlier, I think it's 1 or 2 slides after this, that you simulated probably showing us probably 6 compounds or so for the under under prediction of a couple of compounds. Yes, right here. So my question is under prediction just because of the under prediction happen in the oral absorption, or just a total metabolism part?
No, I think this was really more of a metabolism part rather than the oral absorption.
Okay. The reason I ask is that the oral absorption part of the condition wasn't that clear, but that pretty much all of the parameters are kind of unknown or not much of the literature
Well, there was some information. Some of the parameters we did have a pretty reasonable parameters. So things like intestinal length and radius. Again, we did have information on the overall growth of the intestine. So if we assume that it's growing proportionally, then and kept the same sort of split of duodenum, jejunum, ileum, colon. So that we made some assumptions, assuming that the entire intestine is growing proportionally, but that allowed us to scale it to the length and radius. So with those, we do have quite a bit of confidence. The transit times do become more dependent on what method was used when they were measured. So there is more variability in those, but
I'm not worried about the intestinal length and radius, but I more worry about the stomach pH, volume, and also the transit time. And then stomach volume and the stomach pH probably relate to the gastric emptying time and also the transit time. So some of the drug might be a pH dependent, especially that drug. It's really tough to predict without the information, especially in pediatric. So that's based on that thinking. I kind of thought about that might be that the prediction might be for the absorption part of the prediction may not be good enough to predict clearance or metabolism or something like that.
So yeah, there is quite a bit more uncertainty when it comes to the transit times, volumes. For the pH, the only thing that we were able to find was that it really drops down very quickly within few weeks after birth, and it's at adult levels. But then again, when we are talking about very young neonates and infants, it's the food, right? You are not going to have a baby fasted for 8 hours to get them into fasted state. And so, the food will be the other aspect of affecting all of these parameters as well. So that complicates the physiology as well.
Okay, thank you.
All right, thank you. Next question: is there any attempt being made for predicting metabolism-mediated hepatic toxicity in pediatric population? Where are we, and what needs to be done in that regard? This question is by Viera Lukacova.
So when it comes to the hepatic toxicity, this would really come down to being able to predict really well the concentrations of the drug inside the liver. So this becomes a lot more difficult to validate because a lot of data, even if we manage to find the data to validate our pediatric predictions, it becomes more difficult to, it's all based mainly on the plasma concentrations, maybe drug secreted in urine, mass balances, and so on. But validate the prediction of the concentration inside the liver, that becomes more difficult. And it would be easier, and it is easier for the compounds which have that quick distribution, so we don't have the permeability or transport aspect. But when it comes to transporters, again, you may have higher or lower accumulation inside the tissue. So it's really a matter of learning more about the physiology of this compound, of filling in the gaps in physiologies. And the other aspect is maybe we need to start linking these more into the PD effect and start using the PD aspects to validate some of the concentration prediction.
Thank you. The next question is from Wen Lin. Does pediatric ACAT model allow us to input an ontogeny profile for enzymes or transporters by the user?
So you cannot enter the profile, so you cannot define an equation as to how the expression level should be changing with the age. But you can create your user-defined ICAT physiologies for specific ages and enter the expression level, the exact expression level for that given age. So again, you cannot just enter equation, but you can create physiologies for given age where that ontogeny would be accounted for.
Thank you. Next question is by David. For the scaling up of renal clearance from in vivo data, do you think it can be extrapolated to other transporters and tested?
That becomes a more tricky aspect. There really isn't enough information to see how in sync the transporters in certain tissue are developing, whether they are all developing at the same time or whether there is more differences. Whether some transporters are developing faster than the others, that information is still not available. So for now, I would really keep it within the same transporters. I don't know if we can extrapolate between transporters. Then again, the more complicated aspect with the transporters is the specificity. That the transporters tend to be less specific than the enzymes. So maybe they just pick up for each other, so that it's difficult to say. We have not done enough work yet or enough of these scalings to be able to say whether we can venture into other transporters or whether we have to stick with the transporter that was tested.
Right. Thank you. The next question from June Chen. Great presentation, Viera. Can you comment on the advantage or outstanding points of the GastroPlus Pediatric module as compared with other tools?
So it's really a little difficult for me to comment because, well, obviously because of the bias. The other aspect is I don't really have access to the other tools. So all I can do is really just based on opinions and gossip that I've heard. One aspect that I think does provide an advantage that it is integrated within the PBPK module. So the pediatrics are not a separate module. It's all one continuum within PBPK module within GastroPlus going from pediatrics up to adults. So you don't have to keep switching. The other aspect which may be advantage or may not, and again, I cannot confirm, so maybe I'm wrong here, but also comments that we've heard was that GastroPlus provides more flexibility. So it may allow you to get more special cases, not typical physiology changes. But again, this one I cannot say for sure because I haven't seen or haven't worked with other tools enough to confirm that it really is the case or not.
All right, thank you. The next question from Krishna. Has the influence of any major pathological conditions characterized?
So we were looking at the the typical liver cirrhosis and the renal impairment, but these were so far the simulations that we've done were all in adults. So we were able to scale the processes that would be affected in the renal and the hepatic impairment, but it was done mainly in adults, not so much in pediatrics.
All right. Thank you. Next question for oral, the question from Virginia. For oral administration in children, is there any scaling for the gut physiology according to the age or not?
Yes, so especially the parameters that are shown in this slide, the ones where we had at least some quantitative information, these are getting scaled according to age. So the changes in the growth of the intestine, the transit times, the stomach volume, pH, as well as the some of the transporter and enzyme expression levels are getting scaled. We may have more or less confidence in some of these scalings, but they are getting scaled based on the information, the best information we were able to find so far.
Okay, thank you. Question from June Chen again. The current pediatric module is not working if compartment distribution model is used. Is there any improvement or change in the future, possibly?
So what we can scale physiology. So we cannot scale the compartments. If you are using compartmental PK, it's really not physiological model. So that one we cannot scale very well down to pediatrics. The PBPK models are being scaled because that's a physiology and we know how to scale that. That being said, though, the intestinal physiology is getting scaled even with the compartmental model. But if you are using compartmental PK, the intestinal physiology scaling is based on the body weight. So assuming that the body weight is a typical body weight for given age, we do scale the intestinal physiology. But the compartmental PK, that's not something that we can scale because it's more of a compound-specific rather than physiology-specific description.
Thank you. The next question from David. Good. Can GastroPlus incorporate the different protein binding kinetics into the FU, which I believe is fraction unbound calculation, like albumin, AAG, HDL, etc.?
Not yet. So right now it's all based on the fraction unbound, and as I was describing, we are doing the fraction unbound more based on the total protein binding, so not in the individual components. We do have in our never-ending list of future improvements the aspect of incorporating binding kinetics, even though I'm guessing in the first implementation, once we get to it, would be still a binding kinetics to the protein overall as a general protein. It is possible, we may consider that in the future improvements to look at the kinetics in individual parameters. The decision does become question of having a model that can still be reasonable parameterized, because putting in more details will also require having more physiological and proper physiological descriptions for all of these parameters. So we will have to see if we can get all of that that special information. But so incorporating kinetics is definitely something that we have in plans. Whether we'll or how soon we would make it into individual components, we haven't decided yet.
All right, thank you, Viera. The next question from Rupesh. Does the variability in enzyme expression in both gut and the liver is incorporated in the present model or in upcoming models?
It is incorporated in terms of population simulations. So when you do population simulation, the enzyme expression or the variability in the enzyme expression levels can be accounted for, and the default CVs for the CYP enzymes, especially those in the liver, are based on the physiological information in the literature. So those are not just something that we made up, those are real reported values. If by variability you meant a polymorphic expressions, poor and extensive metabolizers, that's again something that you could incorporate by changing the expression level in the physiology. But the variability in the expression, the general variability, would be accounted for within population simulation.
Thank you. The next question from Natalie. From the difference ontogeny that you just showed, it would seem that more or less everything is at adult level at around 10/12 years old. Hence, weight scaling would be enough. Is that correct?
For the CYP enzymes, that would be a correct statement. The CYP enzymes, but by about 10-12 years old, you are close to adult levels. It becomes tricky below that because some enzymes do reach adult levels within 2 years. Some enzymes take 5 years. Some enzymes are at 10 years old. And again, what I was showing that applies for CYP enzymes. We have seen some reports that other enzymes may actually go through boost in expression levels in puberty. So at certain age, they may actually exceed adult levels. So it does become more complex, but if we're talking only about CYP enzymes, that statement would be correct.
Thank you. I have someone raise their hand. Let me unmute. Hello?
Can you hear me?
Yes, go ahead.
It's Herbert from University Ghent, Belgium. Just to make a comment on the last topic, I think CYP enzymes are, let's say, at about adult levels. If you're talking about 10 to 12-year-old, but this is mainly fraction of adults, so this does not take into account the liver maturation. This one. So this is fraction of adult really, and this takes not into account the tissue growing.
Yes, that is correct. These ontogenies are really just the functional or per gram tissue. The tissue, of course, continues growing. So past that is the tissue size that affected more.
Okay, thank you. And then maybe just one question concerning again the fraction unbound correlations. I think fraction unbound at this time in pediatrics is calculated using measured protein concentrations, right?
Right now, what is more, the fraction unbound in general, at least my understanding is that it's measured as fraction unbound. That it's not that people are not measuring the protein concentration specifically, but they would be measuring the fraction unbound in the plasma.
Yeah. Okay. But the point is that the fraction unbound to pediatrics is scaled from adults by taking into account the different protein concentrations in pediatrics.
Yes, that's correct.
Yeah, okay. And have you taken into account the fact that, for example, in newborns, there is in a lot of cases there is elevated bilirubin, which can also cause competition for protein binding, but that is not taken into account. Let's say the protein concentrations at that point won't be as much informative as without bilirubin.
Yes, that is a good point. The effect of bilirubin and possible competition of the binding to bilirubin is not accounted for in this equation. One of the main reasons was that it would be more specific to certain drugs, and we just did not have the kind of data to validate it yet. So, and also it may be dependent on the condition, right? So not all children have that increased bilirubin. So here the scaling was based more on the most generic parameters, which we know how they are changing. But that is a good point. Again, one of those aspects to keep in mind when trying to predict those young children. And if you are trying to predict in those ages or in the condition where you expect that bilirubin to be higher, maybe exploring some sensitivity and looking at how that might be contributing would be in order.
Okay, thank you. And then maybe just a last question concerning the binding kinetics of drugs with albumin. Don't you consider binding kinetics for albumin to be, let's say, a very fast process considered to tissue distribution or metabolism, let's say? So in other words, should we take into account the binding kinetics of drugs to albumin?
Well, that's what we are assuming right now. Right now, the model is assuming that the binding to the albumin is quick and linear process, so it's just modeled through a few. But we have seen through our customers that occasionally there comes a drug where the kinetics may have an effect, or maybe a saturable process, so the kinetics may need to be taken into account. Vast majority of the compounds is still well described by just the simple assumption of fast binding, but that may not be the case for every compound.
Okay, thank you.
Thank you. I saw Viera Lukacova. There's still raising hand icon here. I'm going to unmute the line. See if last time we didn't hear from him. Hello,
hey,
Viera.
Okay.
Still no.
Viera Leonard, you still online?
Hello?
Yep.
Yeah. I'm sorry.
Yeah, go ahead. You had a question?
Go ahead.
No, I already asked my question.
Okay.
Oh, great. Okay, thank you. Now here, I saw the last question is actually a request. It's asking you, Viera, whether the presentation PDF copy can be shared in today's webinar.
Yes, sure. Just like every webinar, we will make the slides available, and also the recording of the webinar will be available.
Very good. Very good. Let me just double check there. June Chen, you have your question has been answered, right? I saw the question mark next to your name, so I believe you have Viera already answered your question.
Yep.
All right. I guess we are getting very close to the end of our time here. Thank you, Viera, for answering those questions. In case you have additional questions after the webinar that cannot be answered today, please go to our GastroPlus User Group LinkedIn website where you can post your questions. Your questions will be addressed by Viera or by our members in the simulation class. So thank you again, Viera, for the presentation and answering questions. For the audience, thank you all for your participation. You may now disconnect from the webinar. Thank you, everyone.
Thank you, everyone. Bye.